Hi, this is Dr. Len Calabrese from the R.J. Fasenmyer Center for Clinical Immunology, and welcome to Rheumatology Virtual Grand Rounds. Great pleasure to have one of my colleagues here, Mehrnaz Hojjati, who heads our lupus efforts here at the Cleveland Clinic. And she's going to talk about one of the more problematic aspects of lupus. Lupus is a big disease. It can be asymptomatic and fulminant. It can range from being multi-system to a single system. One of the more problematic complications are selective cytopenias, and ITP is one of the most challenging, and there have been some recent advances. So I'd like to welcome Mehrnaz to our program.
So good afternoon, everyone. I am associate staff at Cleveland Clinic Rheumatology Department, and I'm going to discuss managing single organ SLE today as a manifestation of ITP. I have nothing to disclose, and I have 3 learning objectives today. My first objective would be describing the pathogenesis of hematologic complications in lupus. Second objective would be describing commonly used agents in the management of SLE-associated ITP. And finally, I will analyze the risks and benefits of biologic agents in the treatment of refractory ITP, including B-cell targeting agents, Rituximab, and the newer Thrombopoietic agents. So just a few words on SLE. We all know SLE remains the prototypic systemic autoimmune disease with a profound female predominance. And as we all know, the diagnosis of SLE can even be challenging at times for rheumatologists due to its multi-phased and complex presentation at times. One of the relatively common organs that is involved and affected in SLE is the bone marrow and its secondary hematologic manifestations with different cytopenias and specifically thrombocytopenia, which I'm going to focus my talk today on. And quite frankly, thrombocytopenia can be one of the initial manifestations of lupus. So knowing about that and taking that into account when you are seeing a patient with diagnosis of lupus as a consult would be helpful in further down your treatment plans. So to start with, well, obviously, lupus is an immune-mediated disease, and the bone marrow involvement is also a part of this problem. The major concept on the pathogenesis of immune-mediated hematopoietic failure in lupus patients involving the bone marrow really gained its momentum after the study, which was a single center study reviewing the bone marrow slides on 40 SLE patients with unexplained cytopenias. And it was reported that the bone marrow biopsy on these patients showed significantly hypocellularity, necrosis, and stromal changes, really suggesting the concept of hematopoietic failure as a result of immune-mediated bone marrow damage in lupus patients. So with that, just a few words on thrombocytopenia in lupus and how frequent that is. The incidence is up to 30% reported in different registries, and it's really defined as platelet count of less than 100,000. It is important to note that the diagnosis of thrombocytopenia or the incidence of thrombocytopenia precedes the diagnosis of lupus in about 15% of the cases, and it is indeed a prominent manifestation in pediatric lupus. Thrombocytopenia is usually associated with other hematologic abnormalities, lymphopenia and hemolytic anemias. Is usually associated with higher disease activity in lupus as well as lupus nephritis, and is directly linked with higher morbidity and mortality as well as organ damage in lupus patients. In a single-center cohort study reviewing 632 patients with thrombocytopenia was reported in over half of the patients, so about 58% of the patients at disease onset or at the time of their diagnosis of SLE had thrombocytopenia. And interestingly, relapse is also very common. Relapse of thrombocytopenia is reported in up to half of lupus patients in the course of their disease. I should also note that thrombocytopenia in lupus is usually mild to moderate and is almost always associated with generalized disease activity. So no specific treatment is needed other than managing generalized disease activity. And severe forms is really rare in lupus, and bleeding complications are really, again, very uncommon unless there is other associated diagnosis going on. So a few words on pathogenesis of thrombocytopenia in SLE. So as I mentioned earlier, for the most part, obviously, is immune-mediated, and there is increasing data emphasizing the role of antibodies, specifically the anti-glycoprotein 2B3A and also anti-thrombopoietin antibodies and anti-thrombopoietin-receptor antibodies being important in the pathogenesis of thrombocytopenia and SLE. So the mechanism, if we divide it, it would be primarily either peripheral platelet destruction and clearance, either due to the presence of anti-platelet antibodies, antiphospholipid antibodies, and also impaired macrophage Fc receptor function, or in conditions like TTP, that there is increased consumption, peripheral consumption of platelets. Or it could be due to bone marrow hyperproliferation in conditions like megakaryocytic thrombocytopenia, or hyperproliferation from the bone marrow due to antibody or T-cell mediated suppression of megakaryocytes, and so decreased proliferation of the megakaryocytes and platelet production. Or in very less frequent and rarer conditions like hemophagocytosis, that there will be intramedullary consumption of platelets. Obviously, we should not forget the non-immune mediated causes of thrombocytopenia in lupus patients, and keep in mind that there are also other causes for thrombocytopenia in lupus patients. Most importantly, drug-induced mediated thrombocytopenia, which could be either due to bone marrow suppression or peripheral destructions, infections, most notably parvovirus, HIV, hepatitis, TB, should be sought in conditions that is associated especially with no other organ disease manifestation of SLE. DIC as a other cause of thrombocytopenia in SLE patients, usually due to concomitant sepsis or other conditions, and as well as myelofibrosis and myelodysplasia. So with that, I want to move to my first case. This way we can kind of follow an actual clinical scenario of a lupus patient presenting with this problem and what would be the best clinical approach in this patient. So my first case is a 20-year-old previously healthy male that presented to me with 10 days of malaise, dry cough, low-grade fevers, pleurisy, myalgia, and arthralgia, and about 5 pounds of weight loss. In his physical exam, he had a low-grade temperature, respiratory rate was 26, and blood pressure was slightly elevated. He had shoddy cervical adenopathy and an aphthous ulcer over his palate. There was decreased breath sounds of the left base of his lungs, and there was a trace peripheral edema over his extremities. His workup showed some atelectasis in the left lobe in the chest X-ray, and CAT scan kind of confirmed the pleural effusion. PE was ruled out. His laboratory work showed he actually was pancytopenic with a hematocrit of 34, a white cell count of 3,500, and a platelet count of 61,000. Creatinine was 1.3, and urine analysis showed 3+ protein, some red cells and white cells with no bacteria and trace leukostrace. Interestingly, his ANA came back positive at a moderate titer of 1 to 320 by IFA in speckled pattern. So with this, we'll move to our first question. What is the likely diagnosis for this patient? 1, pneumonia. 2, adenocarcinoma of the lung. 3, new onset lupus. And 4, lymphoma. I'm going to move to my next slide. So obviously our talk is about lupus. So his double-stranded DNA came back elevated at 150. Complements were low, both C3 and C4, and his CRP was elevated at 22. Peripheral blood smear did not show any evidence of hemolysis, no schistocytes, just some thrombocytopenia and leukopenia, no abnormal other cells. The serum protein electrophoresis was basically reported normal. Antiphospholipid antibodies were negative, and the urine spot protein to creatinine ratio was elevated at 4 grams. So with that, we'll move to my second question. What is the most likely cause of thrombocytopenia in this patient? A, increased platelet clearance. B, elevated antiplatelet antibodies. C, antiphospholipid antibodies. And D, decreased platelet production and bone marrow failure. There is more than one answer that you can select. And so obviously with the initial information that I presented earlier, all of these can be potential contributors to the etiology of his thrombocytopenia, although the antiphospholipid antibodies were checked and they were negative. So just to go a little bit more detail into the pathogenesis of immune-mediated thrombocytopenia in lupus. So, as I mentioned earlier, there is increasing body of evidence that that at least two types of antiplatelet antibodies, so the anti-glycoprotein 2B3A as well as the anti-thrombopoietin-receptor antibodies seem to be the major pathophysiologic mechanisms of thrombocytopenia in SLE patients. And studies have actually showed that in recovering thrombocytopenic patients with lupus that are responding to treatment, the anti-glycoprotein 2B3A antibodies are absent in the majority of patients, suggesting their role in pathogenesis. In addition, there's also increasing body of evidence on the role of thrombopoietin-receptor antibodies, mostly the CMPL. As we know, thrombopoietin is an important moderator in megakaryocyte proliferation and in the bone marrow. What happens is the TPO binds to its receptor on megakaryocytes and signals through the JAK-STAT pathway, inducing the proliferation and maturation of megakaryocytes. And so these antibodies interfere with that and result into megakaryocyte hypoplasia. And this actually has been reported in patients that have or are positive for the CMPL antibody, indicating its role in pathogenesis. It's interesting to note as well that these patients that are CMPL antibody positive seem to be patients that have a poor response both to steroids as well as IVIG. Now, the role of anti-thrombopoietin antibodies itself also has been raised, but there are studies showing that the prevalence of these antibodies, the TPO antibodies, is actually similar in both thrombocytopenic lupus patients and lupus patients with normal platelet count. So it's really unclear whether these anti-TPO antibodies are simply an epiphenomenon or have any role in the pathogenesis. And the other one would be the CD40 ligand antibodies. So with that, I'll move to my third question, and that is what laboratory test can be used to monitor his response to treatment? A, double-stranded DNA titer, B, complement C3, C, antiplatelet antibodies, and D, none of the above. Basically, the measurement of antiplatelet antibodies as a useful method for its clinical significance is really unclear. Whether they're helpful as predictors of serious disease, or it could be used as biomarkers to follow therapy. It's really unclear and it's controversial at this point. The data does suggest that these antibodies, specifically the anti-glycoprotein 2B3A and maybe the CMPL antibody, may be useful in predicting response to therapy in difficult-to-treat or refractory thrombocytopenic patients to steroids and IVIG in different subsets of disease. But again, this needs further data and patients to look into. Now, the other limitations is really these tests have limited availability, they're very expensive, and the time lapse is pretty long until the results come back. And so in the settings, it would be not realistic, at least at this point, to use these antibodies as an indicator for response to therapy. So with all that, I'll move to my second case. And this is an actual 21-year-old female that was diagnosed with lupus about a year prior to this presentation. She was on hydroxychloroquine and prednisone 5 milligram a day. She presented this time with new onset shortness of breath, palpitations, fatigue, and joint pains. Her laboratory evaluation revealed a platelet count of 32,000. White cell count was 3.8. Hemoglobin was 11.1, and chest X-ray again showed some atelectasis. Urine analysis showed a 3+ protein and blood. She got a CAT scan, and this is what the CAT scan showed, basically a saddle emboli in the main pulmonary artery. So the question is, what is the most appropriate laboratory test to order at this point? A, Coombs test, B, platelet antibodies, C, antiphospholipid antibodies, D, complements, E, peripheral smear. And so with that, I'm going to move to a few details on antiphospholipid antibody syndrome and the frequency of thrombocytopenia. So obviously the answer was checking the antiphospholipid antibodies. I should not forget about this in our lupus patient that present with thrombocytopenia. Usually the thrombocytopenia that is due to the presence of antiphospholipid antibodies is mild to moderate, and severe thrombocytopenia is really rare if present. That usually should be due to the co-presence of other antiplatelet antibodies. And should encounter the fact that the presence of antiphospholipid antibodies really does not influence the effectiveness of how we treat our thrombocytopenia, but just should keep in mind that while treating the thrombocytopenia in these patients that have a positive antiphospholipid antibody, they probably have a higher risk of thrombosis while they respond to treatment, so we should remain insightful for this. So in a study looking at close to 1,600 patients with secondary antiphospholipid antibody syndrome and close to 1,500 patients with idiopathic APS. About a third of patients with secondary APS as well as a fourth of patients with idiopathic primary APS were reported to have a thrombocytopenia. So it's fairly common, we should think about it. And also in another report from 4 studies on patients with ITP, with other associated diseases, not just lupus, the cumulative data from these 4 studies showed that about, again, a third, 34% of ITP patients were found to be positive for one or more of the antiphospholipid antibodies, of which about 21% of these patients actually developed thrombosis. So this is something that we should think about, check it, and be insightful about the high risk of a possible thrombosis as we treat their thrombocytopenia. So going back to our case, she had further evaluation and laboratory test. Her sedimentation rate came back elevated at 49. She had a peripheral smear, which didn't show any major abnormalities, no schistocytes, no abnormal cells, and just some decreased platelets. And the urine spot protein, again, was elevated at 3 grams. her antiphospholipid, anticardiolipin, IgM, as well as a lupus anticoagulant. They were both positive in a moderate titer. She was started on low molecular weight heparin along with oral steroids for her thrombocytopenia and other disease manifestations, and she underwent a renal biopsy. On hospital day 3, she develops further problems with nausea and flank pain, gets some blood work. Her hemoglobin comes back at 7.9, gets a CAT scan, which shows a large retroperitoneal bleed. Her platelet count has increased just a little bit, 35,000, and her INR is still non-therapeutic. It's 1.1. So the question here would be, which I'm sure we all may have faced this at one point or the other during our career, what would you do next? So this is a patient now has a bleed with a low platelet count and has antiphospholipid with a saddle emboli sitting there and lupus disease activity. So would you give her fresh frozen plasma? Would you transfuse her with blood, pulse with steroids, or pulse with steroids and IVIG? Probably all of these might not be wrong to do, but, her INR is 1.1, is not even in the therapeutic range. You definitely don't need to still give her blood. I mean, her hemoglobin was 7.9. Her vital signs are stable. So the correct answer probably is giving her a pulse steroids and IVIG that probably has a potential factor when we are dealing with severe life-threatening thrombocytopenia and hemorrhage in SLE patients. And studies in ITP patients probably suggest that corticosteroids and IVIG probably can potentiate their effect and might be a good choice for induction therapy in these situations. Treatment, and so really what is there in terms of what's the best way to treat patients, lupus patients with thrombocytopenia as their major manifestations of their disease. Now, so just a summary, unfortunately, literature addressing the treatment of thrombocytopenia in lupus patients is very limited and is mainly based on case series and extrapolated data from ITP. But as a principle, thrombocytopenia with platelets more than 50,000, even in lupus patients, specifically when there is no other organ manifestations and patients are asymptomatic, necessarily would not need any specific treatment. However, in cases that there is lower platelet count or there is symptoms, so there are treatments available that work in different ways, as we know. And so the first-line treatment traditionally is steroids, prednisone 1 milligram per kg, with tapering over the first 4 to 6 weeks. In refractory cases, IV dexamethasone and IV steroids seems to be more effective. Now, again, as I mentioned, the data mostly is extrapolated from ITP patients, and it's really, again, we don't have any clinical trials for this in lupus patients. IVIG also been reported as a first-line treatment, although, again, the effect seems to be transient and short-term, but in addition to IV steroids, seem to have a potentiating factor and good response, at least transient response. And then more traditional treatments that not used recently, is IV anti-D immunoglobulin. So the data on usage of steroids in ITP, in lupus patients with ITP, is really the concrete evidence is from a single large retrospective cohort of 59 patients with severe thrombocytopenia as their cardinal manifestation. In the study, the mean platelet count was below 30,000, and complete remission was defined as platelet count over 150,000, and partial remission defined as platelet count of 50,000 or above. Patients were treated with prednisone 1 plus minus 0.2 milligram per kg per day, and so what they saw was basically the initial response was great. Over 80% of the patient responded. Complete remission was reported in half of the patient, and partial remission in a fourth of the patient. Sustained response, however, was not good, was only reported in 11 out of the 50 patients, and this was after a mean treatment of 2 to 4 years. Long-term response was not good again. The long-term response was not seen in close to 80% of the patients. And about a third of the patients were actually resistant to the starting dose of prednisone. So how about IVIG? So as I mentioned earlier, again, the use of IVIG in lupus-associated thrombocytopenia is mostly extracted from data and usage in ITP patients. There is a study that actually reported the efficacy of IVIG in lupus patients, an open clinical study which used IVIG 5 days in 31 patients. A transient response was reported in about 65% of the patients, and complete remission was reported in about 40% of the patients. But unfortunately, the sustained response was bad. There was no sustained response reported, and so the authors on this study concluded that probably IVIG does not offer any advantage over steroids in the primary treatment for ITP patients. And although initially probably effective, but the effect is transient and sustained response is not reported. There was also a study of IVIG in a small open clinical study of 7 patients with lupus and associated thrombocytopenia, and this reported over 50% increase in platelet counts was reported in 5 out of the 7 patients. And there was another report also, I don't have it here, that IVIG was used in 3 patients with lupus and associated thrombocytopenia, and all 3 had a rapid, but again, temporary increase in the platelet count. Again, use of IVIG seems to be effective initially, but the response is transient and is usually counts are reduced after 3 to 4 weeks. Again, mentioning how IVIG works, it probably blocks the Fc receptor of the phagocytic cells, leading to reducing the platelet destruction by the phagocytes. And it's not dependent on circulating antibodies, which seem to be the main pathogenesis of thrombocytopenia in lupus patients. So following up, On our patients, 2 months later, you see her in the clinic complaining of menorrhagia. Platelet count is 30,000. She's on prednisone 20 milligram a day. Increased her steroid dose. She returns back 2 weeks later with persistent menorrhagia and platelet count of 34,000 only. So what would be the next step at this point? You will switch her myclophenolate to azathioprine. You will start her on Rituximab. You will refer her to the surgeon for a splenectomy. You'll start her on the newer Thrombopoietin-Receptor Agonists, or you start plasmapheresing her. And the answer is, probably trying Rituxan at this point. So with this, I'm going to move to second-line treatments for thrombocytopenia in lupus. And so just again, as a general line, our experience with usage of other immune suppressive medicines targeting specifically SLE thrombocytopenia is really limited and is really, most cases, therapy really depends on the coexistent disease manifestation of SLE, and based on that, the choice of other immune suppressive therapy is usually made. There is really, there is case reports on usage of azathioprine, cyclophosphamide, cyclosporin A, really not very promising. Dianazole in refractory cases, dapsone, and also a few case reports on myclophenolate and its efficacy in more refractory thrombocytopenias. But again, the data is very limited. Cytoxan probably is the most effective in refractory severe cases. There was a case series of 7 patients with refractory thrombocytopenia to splenectomy and steroids, requiring higher dose of steroids, which received pulse Cytoxan, and all of them did very well and had a good response. In terms of dianazole, this is actually an interesting, we don't know exactly how it works, but there was a French study on 18 patients that received thrombocytopenia with ITP that received dianazole and added to their prednisone 0.7 milligram per kg a day, and around 12 of these patients had actually received other treatments, but about 50% of these patients had a sustained long-term response after receiving dianazole. These patients were followed up for an average of 2 to 3 years, and complete remission was reported in about a third of the patients. So dianazole, an interesting drug that seems to be somewhat effective, but again, the data is very limited to very small numbers. Now, also usage of myclophenolate. Again, there was a open clinical study of 6 patients with ITP with various secondary disorders, not just lupus, and 2 of these patients had complete response. 3 had some partial response, and 1 didn't. So again, mixed data on efficacy of myclophenolate in ITP. So how about splenectomy? So the role of splenectomy really remains a matter of debate, specifically on our lupus population, due to higher rate of infections and other complications. There was a French study that looked at 17 patients with a platelet count less than 30,000. They underwent splenectomy. Again, sustained response was seen in about 65% of the patient. Complete remission reported in close to 60% of the patient, and partial remission reported in 6%. But about 40% of the patients actually had a recurrence of their disease and SLE flare within the first about 2 years after the splenectomy. So the role is really debated in lupus population, specifically with the higher risk of infections. So how about newer therapies, novel treatments? Try to summarize the 3 novel therapies that we have: Rituximab, Romiplastim, and L-Thrombopac, which are the Thrombopoietin-Receptor Agonists. How they work, what's the time to response, average time to response, and the average duration to response reported in studies. So for Rituximab, seems to be around 10 to 11 months. And for the other 2 novel treatments, seems that the effect is seen as soon as 2 weeks after discontinuing the medication. The platelet drops back down. So just a few words on the usage of Rituximab. Although, unfortunately, both of the major clinical trials and use of Rituximab recently did not reach its primary endpoint in both our generalized lupus activity patients and lupus nephritis patients, but it remains to be a medication that is used quite commonly off-label in our lupus patient as well as patients with ITP. So there's obviously increasing data on the role of Rituxan in ITP patients, but again, in our lupus population with thrombocytopenia is limited to case reports. It seems, as a summary, that Rituximab is effective in refractory cases of thrombocytopenia in our lupus patients, but sustained response is not ideal. So in about 10 or 11 months, that's the time lapse for recurrence of the disease. Now, I found this study that actually reviewed the literature on usage of Rituximab in ITP patients, included 19 case series that had over 375 treated patients with Rituximab, and reported up to close to half of these patients actually went into complete remission with usage of Rituximab. There was a controlled trial reported that 31% success rate was reported, and then there was another study that above half of the patient achieved stable counts over 150,000 without additional therapy for lasting for at least 6 months. So seems to be a promising, effective treatment for ITP and certainly also for ITP associated with lupus, but relapses can happen, and it's common in up to 50% of the patients, usually after the first year or 2. So again, just a few words on our novel treatments, Thrombopoietin-Receptor Agonists, how they function. So basically, they go on, sit on the thrombopoietin receptor on the megakaryocytes, and through this, they activate thrombopoietin, and that signals the JAK-STAT pathway, inducing megakaryocyte proliferation and differentiation into platelet production and increased platelet induction. So on the usage of, there's 2 thrombopoietin receptor agonists available now, FDA approved for treatment of ITP. These are not studied, have not been studied in SLE-associated ITP. And the first one is Romiplastim. There was 2 phase 3 placebo-controlled randomized trial for 2 and 24 weeks. Had 125 patients with ITP enrolled, platelet count less than 30,000 again, primary endpoint of reaching at least 50,000, platelet count of at least 50,000 for at least 6 of the final 8 weeks of therapy. And these were studied in both splenectomized and non-splenectomized patients. So what they found was 63 out of 125 patients underwent splenectomy and 62 did not. Sustained response was reported in 38% of the splenectomized patients and 61% in the non-splenectomized group compared to none in the splenectomized placebo group and 5% in the non-splenectomized placebo group patients. So it seems to be very efficacious with a significant p-value. The other thrombopoietin-receptor agonist is Erythematosus, which again, a 2 6-week placebo-controlled phase 3 clinical trial was performed on this medicine and an open-label extension study with similar primary endpoints. A total of 118 patients were enrolled, and basically the results show that about 59% of patients in the treatment group achieved its primary endpoint compared to only 16% in placebo. So it also appeared from this studies that both of these medications, patients that were on these medications were more likely to reduce or discontinue concurrent medications, including steroids, and required less rescue medications than the placebo group. They also had less hemorrhagic complications. So how about hematopoetic stem cell transplantation? Again, this is based on just a few case reports. It seems to provide remission in a limited number of patients, but it is associated with major fatal toxicities, including graft versus host disease and septicemia. So to summarize, as your take-home message, so immune-mediated thrombocytopenia in lupus is almost always associated with other systemic manifestations of the disease, which will usually respond to treating lupus. It would be very unusual that their thrombocytopenia would not respond to whatever immune suppressive treatment you're using to treat their generalized disease activity. Antiphospholipid antibodies are a common cause of thrombocytopenia. They should be looked for, and presence of those antibodies does not appear to influence the treatment response, but is probably associated with high risk of thrombosis. Rituximab is a promising treatment for refractory immune-mediated thrombocytopenia, but should encounter the fact that the relapse rate is high, up to 50% after the first year. Refractory thrombocytopenia in lupus, especially in the absence of systemic features, should make us think about other diagnoses and other diagnoses of thrombocytopenia, not necessarily immune-mediated, and think about other differentials, infections, medications, etc. And finally, the novel treatments, usage of thrombopoietin-receptor agonists seems to be very promising for treatment of ITP, but both of the major clinical trials have evaluated patients with ITP and not ITP patients with lupus. So this needs to be looked into and further studied in our lupus population before we can really extrapolate the data to our lupus population. With that, I will conclude my presentation. I hope this will give you a brief insight on thrombocytopenia in our lupus patients and how and what is the best way to manage these patients. Thank you.
Thank you, Mehrnaz. That was really excellent. You know, the take-home points that I get from this is that, you know, there's no single approach to this, and there are gradations of therapy. And while glucocorticoids have got us a long way, we now have new biologic options. I think that Rituximab, we all have a familiarity and a confidence in this drug, even though it is not approved for this indication. And more recently, the growth factors for platelets have added an extra dimension. Overall, I think this requires shared and informed decision-making with the patient, being able to accept risks versus benefits, and as always, lupus is a challenging disease. So I'd like everyone to come back to Rheumatology Virtual Grand Rounds. We have lots of great cases. Come back to the site and come back to Biologics 5, which is now being posted on the web. Some of the best speakers in the world on the topics of biologics.